Hello, everyone, and welcome to our BSI Net Zero Week in Healthcare webinar. Very pleased to have everyone joining today, and we have an excellent panel of speakers and panelists that we're going to hear excellent information on, and that we can ask questions of. So, to get us started, my name is Lena Cordy Bancroft. I'm sector lead for medical devices here at BSI, and I'll be moderating the webinar and the panelists. To get started, let's go through some basic housekeeping. This is a listen-only webinar that is being recorded. There will be an opportunity to ask questions via the Q&A box button on the side panel. You can post your questions there, and then I will direct them to the moderators, or to the panelists after all the presentations are complete. If you experience technical difficulties, just submit your issue via the Q&A function, and my technical colleagues will be able to help you with that. Upon completion of the feedback survey, BSI will send a link to the recording of the webinar, so you'll be able to access it and share it with colleagues as you wish. Also, this is a CPD recognized webinar, so if you require a certificate, please request that via the feedback survey following the webinar. So just to give some context to healthcare and sustainability and circular economy, I want to just give a quick overview of what our industry is facing. When it comes to circular economy, we need to keep in mind that there are many different devices and many different approaches to becoming circular or sustainable. Every device is different, and so every manufacturer's journey for that device is going to be different as well, because of the unique where they are, their uniqueness as an organization, their unique business needs, where they are with their supply chain, and so on. So every path is different, and so to put out a standard, this is how you do things, this is how to become circular, is very difficult to do. We need to consider that when we say, oh, let's make our devices single use, not every device is going to be able to be single use, and there are very specific reasons for that. Maybe it's it could be due to supply chain, it could be the unique material that it is, it could be due to patient safety, or the intended purpose of that device. So we can't. It's difficult to group all of the various interventions into, for example, one standard or one statement to say, oh, make the device reusable. We need to consider different pathways to becoming much more circular within healthcare. It's also important to know that our pathway, that journey to becoming a circular economy and sustainable, is not an endpoint. It's not something that we reach and then our transition or our journey is done. It's something that's going to continue to change, and continue, something that we need to continue to work for. There will be highs and lows. There will be times when we are much more sustainable or circular with our devices, and times when we may need to resort to different changes in supply chain or changes in transportation. So we may not be as green or as sustainable as we would like, but we have to look at that continuum and the average over a period of time for that. There are many different challenges, and we need to look at this in a unique perspective, knowing that not that every device is different and every manufacturer's journey for that device is different as well. Next slide, please. So some of the key challenges that we face in this journey towards circularity in healthcare and medtech are really related. Many of them are related to the regulatory environment. Very unclear regulatory and customer requirements. Those requirements could be conflicting. For example, healthcare or the NHS is asking for could be different from another jurisdiction, or even the regulatory requirements. So we have some challenges there we need to face. There's also jurisdiction centricity, where what we are striving for or what the regulations ask for in the UK may differ from what is being done in the US or Australia and elsewhere. There are inadequate infrastructure and resources, especially in the UK. If we were to shift entirely from single-use to reusable devices, do we have that sterile processing infrastructure to support that? There's also resource need challenges with take-back initiatives in hospitals and just general resources. Where do you find the space and capacity for that? And then the ever demanding requirements for data to support this move towards circularity, whether it's for procurement purposes, regulatory approval, or even just the lack of being able to share with competitors and share best practices rather than everybody investing money on the same type of research. Next slide, please. And then there are a number of circularity initiatives that are being done. Everybody, I'm sure, has heard about the London Declaration, which was done basically striving forward to push ISO, the International Standards Organization, into incorporating sustainability and climate science into the standards. JAG5 is a joint advisory group. It's a coordination between IEC and ISO on advising on issues related to life cycle of medical devices, and came up with recommendations for standardization activities related to medical devices. And this is work that is in progress at both the IEC and ISO level. And then specific within the UK, we have the Design for Life Collaborative, where it's a community of stakeholders across government, manufacturers, NHS, to come together and think about how we can incorporate these climate science into the standards, what we need in order to become more circular within the UK. And then there will be an action plan and measurement framework published in the future related to that. Next slide, please. So with that, I would like to introduce our panelists, our panel speakers today. We'll start with Lord James O'Shaughnessy. He's the Senior Partner of Newmarket Strategy and former Health Minister. He led an independent review of commercial clinical trials in the UK for the British government, which was published in May of 2023. James has operated at the highest levels of government, including as Minister at the Department of Health and Social Care, as Director of the Number 10 Policy Unit, and as an advisor to DHSC ministers during COVID-19 crisis. As Minister, his responsibilities included implementing the life science industrial strategy, delivering a new pricing scheme with the pharmaceutical industry, and chairing the National Genomics Board to drive the digital transformation of NHS. We're very pleased to have Lord James O'Shaughnessy speaking with us. He'll be the first speaker and talking about the aspect from a government perspective. Followed by Lord James O'Shaughnessy, we have Dr. Philip Corsa, who is the National Associate Clinical Director at the National Centre for Sustainable Delivery in Scotland. He has held a number of medical leadership portfolios within the NHS, and he has recently been appointed the National Associate Clinical Director for the Centre for Sustainable Delivery, or CFSD, in October of 2021, while maintaining clinical practice in intensive care medicine. At the Centre for Sustainable Delivery, Phil serves as the Senior Clinical Leader for the National Green Theatre Program, which has demonstrated that they can make effective and operational clinical improvements while being environmentally sustainable. Following Dr. Philip Corsa, we have Dr. Mary Riordan, who is the co-founder of HapPPE Earth. She has 18 years in clinical medical practice, the last 8 being involved with the public health medicine, specializing in emergency response for highly emerging infectious threats. She is highly interested in bringing practical, sustainable, and circular solutions to address the single-use plastic problem within healthcare and similar industries. And as HapPPE Earth, they champion sustainability and circular economy by bringing together a system for compostable PPE products that can be converted with hospital food waste. Lastly, we'll have Emma Rogan, Development Director for Investing in Children. Investing in Children is a children's rights organization based in the northeast area of England, which works to facilitate dialogue between children and young people that results in meaningful changes to the services that they access. Emma is responsible for overseeing the work that overseeing the work that's done with health partners within the region, including type 1 kids that works with children and young people with type 1 diabetes. So we'll hear 4 different perspectives on circular economy and sustainability within the UK healthcare system. So with that, I'll turn it over to Lord James O'Shaughnessy. Thank you for joining us today.
Morning, Lena. Thank you. I hope you can hear me okay.
Yep, you're good.
Good, very good. Well, thank you for the invitation to speak. And I'm here, I guess, in sort of 2 capacities. One as a policymaker in the way that Lena described, which also included chairing the advisory group for the Design for Life programme, and also as somebody who now works with dozens of companies in this space who are worrying about the subjects that we're discussing today and interested to know where government policy is heading. So that is the subject of my talk. If I can get the slides going. There we are. What I'm going to do is just start talking about the nature of the problem. You'll be familiar with this, but I'm thinking of it coming from the perspective of those who are working in government. The interesting and quite remarkable fact that I've started with is that NHS in England produces roughly the same greenhouse gas emissions as Denmark. So it is a small country in its own right when it comes to its climate impact. We know that climate change is a threat to health. The WHO estimate around 250,000 additional deaths per year between 2030 and 2050 as a result. But healthcare's global footprint is also very significant in driving that. In fact, it's larger than aviation and shipping combined. As a consequence of that, and in the context of overall government net zero targets of 2050, the NHS has its own targets in England, which is to reach net zero by 2040. So actually a more accelerated pathway than the rest of the economy. There are lots of obvious ways that one could think about the impact of that. And as you'll see in the chart on the right, a lot of that comes from inputs, medical equipment, medicines, other supply chain impacts. But it's also about the nature of how care is delivered. And we've heard a lot recently through the Darzi review about the need to shift care models from hospital to community. Well, that in itself may have impacts on emissions and something we need to think about as we go forward. A case in point is the plastic waste that is produced by the medical industry. The facts on the right are, again, some of the figures about the impact of that waste and the proportion of plastic waste that is created by the medical sector. Nearly 6 million tonnes of medical waste produced annually in the US alone. And yet, if we look at overall collection and recycling rates, they're incredibly small and much lower than they should be. And of course, we know where that kind of waste ends up. The case study on the right is around e-waste. So obviously the use of or design of medical technologies which now have some kind of electronics and digital technology in them, often alongside single-use plastics. And we can see that the global market for that is already 30 billion just a few years ago pre-COVID and has massively increased since then. The NHS, of course, recognises that this is the case and is determined to do something about it. As you will see, it has a roadmap for the different areas of focus that need to be attended to in order to reduce emissions. The really important bit for me is not only does the NHS need to change its own behaviours, which is sort of most of the graph until you get to the far right, but actually if you look at, and I'm sorry these haven't quite come up, but if you look at the big blocks where the big gains are going to come from, those are supply chain issues. Those are from industry. They're from the medicines industry and they're from the medical devices, technology, consumables industry. And they make up at least half of the total contribution. So the critical point I want to get across here is that everyone recognises that without industry's participation in this process, which bearing in mind for the UK, this point Lena made about cross-jurisdictional divergence, in the UK that is faster than the overall economy plan. And how that is going to be delivered and the tension between that result remains to be seen. In in terms of how the government's approaching this, I wanted to give you just a bit of context again about what those net zero initiatives are and the binding nature of them. COP26 was quite significant in bringing human health into the forefront of climate change work, and a lot is going on now in that regard. We've got a health program now within the United Nations framework, and over 80 countries have committed at a Minister of Health level to strengthen climate resilience and lower emissions of health systems, the UK obviously included. And there is now a new platform that's led by the WHO in order to help deliver those commitments. So I think, not that I'm sure anyone here is labouring under the illusion that this might somehow go away or be eased, but I think probably over time this is only going to ratchet up the pressure to achieve net zero in a global sense, and at least at the 2050 deadline, if not earlier. Lena's already mentioned this, but I think it is just worth pausing on the work of Ellen MacArthur and her foundation. I actually had the chance to meet her about 13, 14 years ago when I was in Number 10, when I'd never heard of the idea of a circular economy. She's obviously an incredibly remarkable and compelling woman, and she was championing this idea, which has gone from being, I think, quite niche to really quite a dominant concept. I'm sure, again, people will be familiar with what the circular economy means, but it means that materials never become waste and nature is regenerated. So you're constantly trying to upcycle materials. And it's based on three principles: eliminating waste in population, circulating products and materials at their highest value, so the upcycling, and regenerating nature. And she has become, her foundation has become very influential. If you didn't have time to dwell on Lena's slide earlier from her foundation, I would certainly encourage you to do so, because it really underpins a lot of the thinking that is relevant for our sector. So now on to what the UK government is doing about this. The sort of signal document, one of the signal documents here is the DHSC's MedTech strategy, first published in 2023, and then a year on or so, an update was published. This, as far as I know, is still public policy. We know, obviously, there's been a change of government over the summer, but I think we can have a high degree of confidence that the ideas and actions programme and so on within this technology strategy will continue. And there are some very important commitments here around resource security and efficiency. So firstly, as we've already heard, reducing the volume wherever possible of single-use devices, and increasing adoption of multi-use and remanufactured solutions, reducing the overall quantity of plastics that are used and the proportion of virgin fossil fuel-based plastics, collaborating with industry and research partners, so making sure the government is not just telling people what to do, but it was understanding what is possible and how with those who are expected to deliver it, and then working on that. And of course, implementing commercially viable models to increase levels of reuse, manufacture and materials recovery. And I'll come to some of the actions that agencies like NICE, the MHRA and others are taking to promote that view. I mentioned the Design for Life collab program and the advisory group. Lena's already mentioned the collaborative. This is a really important program nested under the MedTech strategy that has brought together many organisations across the sector through a process of participatory activity to develop policy recommendations, which have then been nested under a set of initiatives that the government is now taking forward. And indeed, I've had confirmation from officials in the department that this work has been given the green light to continue. So we'll see that being fleshed out over the rest of this year and indeed into next year, with those moves to support a circular economy as the default approach across medtech. And these recommendations themselves are being combined into sort of three main buckets of activities: a roadmap for the sector with a vision, a clear articulation of problem statements and sub-issues. A lot of work went into that, and I imagine lots of people on this call were also involved in that. A set of actions that will begin to explore how to deliver that with collaborators, particularly industry and the research sector. And then with the research sector, a set of ideas and research interest combined into a document that will look at and address evidence gaps. And here we're going to see, I think, some really interesting future work supported by UKRI in areas like digital enablement, behavioural insights, sterilisation infrastructure, and so on, actually taking place within healthcare settings. The NHS, of course, has published its own net zero supply roadmap, and there is intended to be a great deal of similarity between these two documents. The NHS, as is, I think, obvious from this graphic that we've used, understands that a lot of that carbon footprint is coming from the supply chain, and has developed a net zero supplier roadmap to give some specific dates around when different compliance expectations will come through. And you can see here on the right, we've been moving from recognition within procurement for net zero and social value through to carbon reduction plans, and then for all emissions, and then ultimately product level requirements. And those are coming quickly. 2028, from April 2028, that is only 3.5 years away. So we are moving forward very swiftly in the UK. Just some other major initiatives that I think it's worth people being aware of if they're not already, which is, of course, this isn't just about the NHS or DHSC. The role of regulators and reimbursement authorities is, of course, incredibly important. So NICE has now included environmental sustainability domain in their new topic prioritization framework, and indeed they are starting to now include that or explore how to include that in the technology appraisals that they do for medicines, devices and diagnostics. There's some big challenges to that, of course, particularly around supply chain complexity, which are not only complex but global, and then making sure that we are not so out of kilter as a country with others that companies don't want to bring their products here. The MHRA, as we'd expect, has an essential role in this, particularly around interesting issues like reusability of plastics that have been used where there's infection risk and other things. The NIHR is now increasing its research funding for areas that promote human health in the face of a changing culture and also climate change, but also funding methodology research to look at how to calculate, monitor and reduce the carbon footprint. There are some technological limitations there. Of course, this is a kind of iterative process. NHS supply chain, which supplies around half of the consumables, medtech devices and other things into the NHS, has set up its own roadmap. There are, of course, concerns about the cost implications of that for the NHS and who will pay for them. And the trade bodies are, of course, doing their own work with manufacturers to help them prepare for this change. Some interesting case studies came through the Design for Life work and I think give an example of the way forward. The Penn Cycle initiative was launched by Novo Nordisk a few years ago, inspired by that circular economy concept, in order to try and reduce a big use or a big cause of single-use plastics in more consumer or patient-led health. Which is, of course, around insulin pens, a collaborative effort with multiple pharmacies, Royal Mail and CCGs as were, ICBs now. And that has led to really quite an important impact on the reduction of pens, or the recycling of pens, I should say, going to into landfill. But we're still at a relatively small deployment, and that now needs to be scaled up into a national program. And indeed, that is probably quite a good example of what's going on at the moment. Lots of pilots, lots of exploration, but not yet a national framework to help guide activities of this kind. And then just some further reflections that came through exposure to colleagues working in industry, and also through the client work that I do, what industry needs to help government achieve its goal of net zero, I should say by 2050, the NHS by 2040, which is a consistent approach to the circular economy, aligned incentives so that there is value back for industry researchers in the NHS, clarity and transparency on that roadmap and expectations to all partners, sustainable funding to help ease that transition, which obviously increases costs, and then consistency in implementation across the NHS. So hopefully that gives you some thoughts about how the NHS and Department of Health and Social Care is approaching the challenge of net zero. Thank you. And I'll now move on to the next slide. And introduce Philip Corser, Dr. Philip Corser, the National Associate Clinical Director at the National Centre for Sustainable Delivery in NHS Scotland. Philip, over to you.
Thank you very much. So I'm Philip Corser. I'm one of the Associate Clinical Directors. There's a few of us, there's about 5 of us, who are responsible for different portfolios, and mine is, amongst other things, sustainability. One of the programs that came out over the last year and a half was the National Green Theatre Programme. It came out after COP26 and after the strategy and the climate change strategy was established in Scotland. And I'll take you through some of the progress that we've made and show how some of the structures, as Lord O'Shaughnessy suggested, might help us take ourselves from the desire and project work to hopefully being a cross system approach. Our vision really was to embed environmental sustainability into every clinical and managerial decision. Sounds fanciful, but I think it's achievable. And I suppose we took theatres first of all because there was a clinical backing, best way to describe it. There was already ground roots movement, I suppose, amongst anaesthetists initially, but going right across the theatre teams for clinicians to look at ways of improving our environmental footprint, by using their expertise as clinicians and experts to make sure that what we did come up with was clinically sound and, if anything, improved the service as opposed to any detrimental effects. So we've set up a board to support the process by measurement and reporting improvement to each other and obviously to the Scottish Government. So this is an NHS Scotland initiative. So you've seen our aim. We approach it in many different ways, looking at different aspects. So estates and facilities clearly within health is a large component of our use of energy, and some to look at. Waste management is one of the areas that pulls clinicians in, because we see that and it's something that they can very much appreciate. Volatile gases was very much the anesthetic domain, and we knew what we were using, and we thought, knowing the environmental effects, we could improve on that, and there's some significant improvements there. And then you've got the reusable manufactured reprocessing devices in clinical practice, which really takes us into the circular economy that we've talked about. So what's our journey? After the strategy was published, the NHS Scotland Climate Emergency and Sustainability Strategy was published. One of the strands of that is sustainable care. And sustainable care includes all care, all healthcare. So it includes medicines and others. And one of the parts of that was the theatre project, the Green Theatre Project. And a lot of the work that we started to bring forward was based on pilot work, which was done in NHS Highland. So just talking about some of the pilots that Lord O'Shaughnessy was talking about, we took about, there were about 40 to start with, and there have been a few since, which have been working through. And by taking the actions and understanding them with our colleagues and coming up with actions for implementation and actions for adoption, since March 2023, this is the work that we've done. We've identified £4.5 million worth of cost savings by doing and delivering environmentally safe care. 15,000 tons of CO2 equivalent emissions, again, significant. And this is just a fraction of what we're reporting. Now, what we're trying to do is to report what we can verify and measure. So there are other things that would fall into our work program and plan, but we have not mentioned here. So there's definitely more to come. And I think the users are finding a certain satisfaction from delivering high quality care, efficient care, and saving the planet as we go. So some of the actions that we released, you may have heard of the we didn't use the word ban in that headline. We stopped procuring it, and this is an anesthetic agent, which was um, one of the worst offenders when it came to environmental sustainability. And there were perfectly good alternatives, either intravenous anesthesia or an alternative inhalational anesthetic, which anaesthetists felt they could very well use. And across Scotland, apart from one or two very specific areas, have taken it out of circulation, which is a very positive move because we can certainly see the CO2 benefits of that. You can see some manifolds, the blue cylinders, those are nitrous oxide cylinders. And most hospitals are built with a manifold like this on an outside wall or in a shed outside with piping all the way through to the theatre suite. And we know that once built, if there are any leaks along the way, we can't do anything about it. So we will vent into the air. We can measure the purchasing and the cost of buying these cylinders as manifold cylinders versus the actual usage in the theatre suite. And there's a huge discrepancy in many cases. So the case for taking away these manifolds and using cylinders in the theatre itself takes away a lot of waste. So that's one of the actions that we're progressing quite well with. And again, the case is very well made. The fluid use machine is that small one in the middle there, which is a suction system. Rather than collecting suction in liters and liters of canisters in theatre and asking theatre orderlies to lift these and open them and put gel and dispose of them, this literally plugs into the disposal system and there is no handling of it. And it significantly decreases the cost of actually transporting fluid and other waste for incineration or other heat treatment. At the top right is Lean Trays. Lean Trays is looking at waste, basically. So you learn to have your trays, you send them for decontamination, they come back. And we found that there were significant numbers of instruments within these which were never used or rarely used, as indicated on that chart there. And by removing them, you can decrease the number of trays you have to decontaminate. Now the benefit of that is, yes, you could save money, but actually it means you could create more trays to use in other facilities. So there's some real benefits to leaning. And the one at the bottom is about a gadget. So that black handle initially was a plastic handle with batteries in it, which was discarded as a once only use. And we found that that was totally wasteful when there was an alternative recyclable re-sterilizable piece of gadget that you could attach to instead. So there's some practical changes that you could make without necessarily going overboard. It wasn't going to cost us too much. It was sensible. It was practical. So I've outlined some of these already. I think the circular economy bit was probably the most challenging, mainly for some of the reasons that have already been explained. But we think from the point of view of the user, the service user, there are some things that are reusable. Theatre hats, for example, and some of the ports that we know are re-sterilizable and are sterilizable and reusable. But then you get into the remanufacturing processes where the manufacturers really need to get involved in that, and even further around to parts manufacturers, where there are the smaller bits. the drill bits, for example, in other parts of the final manufactured piece of kit. So this is an important engagement that we need to have. Clinicians are engaged. At the last meeting that we had of surgical teams from across Scotland, looking at reusable ports, we had a significant input from theatre managers, surgeons, and everyone involved in our side of it. But I don't think we have yet had the full discussion between health and manufacturing services as we could do. So there's a way to go yet. One of the things that we've been doing, just to try to illustrate this, is to use to look at pieces of kit that we use regularly. So intermittent pneumatic compression garments are used on most patients having an operation during the operation, short or long, usually for the longer operations. And it's to prevent venous thrombosis. That is what they're for. Very effective too. But looking at the manufacturing and use of this, that particular garment was designed to be disposed of, but it's got a lot of plastics which could easily be recycled if used appropriately. And working with this manufacturer, we're trying to make sure that it can be washed, re-sterilized, and repurposed back at the manufacturing base to be resupplied, as opposed to going into trucks for disposal. Now, looking at how many we've ordered in the last year, so that's quite a lot of pairs ordered, quite a lot of wastage, and quite a lot of carbon generated by incineration, which we think we can improve on. So there's some significant work around that happening. Some of the questions around using or recycling something like this is around whether it's a class 1 or class 2 medical device. That is a class 1. This is a class 1 device with the challenges that come with that, because it should not normally be on its own be recycled just like that, aside from having all the external work done like sterilization, etc., and recertification. So we need to understand what our devices are and where they fit into the cycle and what we need to do to get them back into circulation. We work very closely with our Scottish Government head of NHS Scotland's Circular Economy Programme, who is very much aligned to us, although she's very keen to make sure that circularity is looked at across all systems and not just the NHS. But the clinicians, national procurement, infection prevention and control, waste management are very much part of our discussion. And because we have a programme which includes all these components, we're able to have that closer conversation without some of the challenges of communication and sharing information. And I think that is one of the strengths of the National Green Theatre Programme in Scotland, is that we know each other, we meet regularly, and we talk about what needs to happen. We challenge each other as well, which is good. So that is a short skip through some of the work of the National Green Theatre Programme, which is based in CFSD. Please save your questions, make some notes of your questions, and we will I'll be able to answer them during the question time. If you want to contact us, there is a QR code, there is an email address, and there's a website for CFSD under which National Green Theatre Programme sits. So you could search for that as it says there. Thank you very much. I'm just going to hand over to Dr. Mary O'Riordan, who is the co-founder for Happiness. Mary.
Thank you, Philip. I think what's great about today's seminar is that there's so many positive things happening across the board. And I'm here to speak a little bit about where the sort of industry side. And we founded this company called Happy Earth. And it really is looking at how we see these single-use throwaway items like PPE. And a lot of people, maybe first initial things when they think about, well, number one, composting medical waste, there's a bit of an ick factor around that. So we have to get over that first. But then also, I think when people think about sustainability and standards, there's a challenge to say, well, will that water down the functional standard? And for us as an industry, or as a business, we said our first rule of thumb is that we will adhere to the functional standards above all else. And I think for us, that was a really good hard stop. And we said, let our creativity for sustainability happen within that boundary. So I'll take the next slide. So here we have some fantastic nurses down in the South Infirmary Hospital in Cork, and they trialled our Happy Apron. Now, the Happy Apron is a very simple item. It's a single-use splash apron. There are millions of them used year on year. In Ireland, we used about 70 million of them during COVID. Each and every one of these currently are low-density polyethylene, and polyethylene is it's a fantastic chemical in a way because it's really hardy, but on the other side, it's about 50 years in a landfill. And if you're producing millions and millions of these, that's millions of tons of waste going to either a landfill or incineration. So with that splash apron, you'd imagine not many people think about it. And I think that's why I really wanted to tell the story of it, because it's one of those throwaway items. We use it because we have to. It's not going to go away anywhere. And it's also, you'd imagine, quite simple to replicate. Now, therein lies the challenge. It's a class 1 medical device, which you have to adhere to, as I said, if we're going to reach a functional standard and protect patient and healthcare worker. But also there's about 8 parameters that it's stretchability, tearability, density, and tensile strength, all of these things that you have to match. So we went out to another sector, that's agriculture, and we looked around to see were there any types of bioresins we could use that would be soil safe and that would give us the opportunity to replicate this particular item. Then we trialed it in our hospital setting in the South Infirmary, and everybody loved it. And I say this not because we're trying to change this thing, but because people actually felt it was breathable because it's a starch-based product, sustainable starch-based product. But also they felt there wasn't as much guilt. If you're using 10 of these a day in a sort of a busy renal unit, you're going to see that waste stack up. So there were 2 great factors. But then, of course, there's the whole area of what does it cost? And when you're buying these things in large volumes, the cost, if it's anywhere above your current plastic apron, there's going to be a cost implication. So that's why we said, all right, as a business, let's look at the entire value chain, because we don't consider harms when we're looking at low density polyethylene in a cost perspective. We just see, okay, well, that's a cheaper item. So I'll take the next slide there. So this is what we currently do. And why I'm going to talk you through what we currently do is so that you can see at every point there are standards to be met and decisions to be made that will impact the cost and also the environment and your safety. So at the moment, we're making these low density polyethylene PPE items with an oil-based, fossil fuel-based resin. That's that very strong and hardy low density polyethylene, which is very difficult to recycle and reuse for these single-use items. They're manufactured often in a very distant location that you must bring in on, which creates more emissions, obviously, with your long supply chain. Also, for pandemic preparedness, it's not the best model to have your supply chain so far away, and we've all suffered a little bit of that during COVID. So if you look at the items, we've got things like shoe covers. A shoe cover is a composite item. It has plastic and elastic, so that's very challenging to actually get rid of it at the end of life cycle. Then we have the apron, used for a very short period of time in your interaction. And when the healthcare worker has finished using that item, they then have to make the decision, where do you put it and in what bin does it go? Now it matters, right? 80% of healthcare waste is non-risk healthcare waste. That includes a non-visibly soiled splash apron. So that should be going into the equivalent of your general waste. However, a lot of people still get the impression that, oh, it's a hazardous waste, it's a PPE item, should go into the hazardous waste bin. Now, you might think, well, better be safe than sorry, but unfortunately, it's about €1,000 a tonne to remove your hazardous waste, and it's about €200 a tonne. And forgive the euros now, but I'll describe it as such first. It's about €200 a tonne for your the non-risk clinical waste. So the decision matters there at that point. So the reason, and when you have it put into your bin and it goes off, if you have it in your hazardous waste, it is leaving your facility as a hazardous waste, which means there are EPA waste management guidelines and standards that have to be met if it's your hazardous waste amount. When we did a study in Ireland looking at what goes into your hazardous waste, and it was a very large sample size, about 50% of Irish hospitals went into this study, we found that 30% of waste that was in the hazardous waste bin should not have been there. That included things like food and tissues and non-soiled PPE from a non-infectious patient. So all of that accounted for larger bills in terms of your waste removal. And the reason that your waste in a hazardous site is more expensive is because, one, you have to have proper removal processes. Number two, in Ireland, we autoclave it for the infectious risk, and then we incinerate it because we don't have enough space, and we incinerate to reduce the amount of landfill that we're using for these single items. That's really expensive in terms of money, but also in terms of the amount of carbon emission. So that's to give you a sort of a hint as to how complicated a single-use splash apron actually is. So then we decided to look at, well, what other waste stream is in a hospital that's really challenging? And with the best will in the world, and with the best efficiencies of how you buy your food and how you allocate the portions and how you store it and stock it, sick people don't have the best appetites. Now, you will provide a meal, but there will always be some element of food waste. So if we look at those two waste streams in a hospital setting, you're always going to have some element of food waste, and you're always going to have some element of single-use PPE usage. So how then do you reduce costs and reduce the amount of these particular wastes? And we said to ourselves, okay, well, there are two things you need to do. One, you need to de-risk it on site, that waste, because that's what the US do. A lot of the cases, they autoclave their medical waste on site, so they reduce the cost to remove it, and then they send it to landfill. But we said, okay, not just reduce your costs in terms of de-risking it on site from a pathogen risk, we also said, could we not create a value product on the site of the hospital that you could then say, well, that's no longer a waste. We're actually making value out of two waste streams that are never going away from a hospital setting. So I'll take the next slide there. So this is what we looked at, and this is what we're rolling out at the moment in Ireland. We started with our class 1 medical device, that is the splash apron and other PPE products in the pipeline from a plant-based material and a sustainable source, a non-food source and bioresin that's soil safe according to the agreed international and standards for compostability. We then manufactured local supply chain because we wanted close to hand for both pandemic preparedness and also for shorter supply chain, shorter emissions. We then use it. It's breathable. It goes into a certain waste stream of our compostable waste stream. That then goes down to where waste is collected into your medicalized biodigester. And I'll talk a little bit about what we did in terms of the biodigestion process. We also then take the food waste and also goes into our medicalized biodigester, and we put those two waste streams together. Now, we're doing the equivalent of autoclaving it on site, because what we've done is we have physical, enzymatic, thermal and plasma-based processes that gets rid of all types of hospital pathogens, also food waste pathogens, and we create this beautiful nitrogen-rich fertilizer. That fertilizer then is no longer a risk from a pathogen perspective, but also we've created now a value product. That value product now goes out into the world as a fertilizer, but you must respect then EPA guidelines for soil. So then you would have to have it under the regulations of, is this a proper grade A fertilizer? What's the contamination like? So we regulate all of that. But the great thing about having a nitrogen-rich fertilizer is that it can also go to other renewable energy sources, such as an anaerobic digestion biofuel source. So you bring that lovely nitrogen-rich fertilizer created by your hospitals to then create a biofuel that could potentially then fuel homes. So this is our looking at that value chain, looking at how you get value out of something and bringing in that circular-based mindset. And just to say, reporting on things like medical waste and your gains and how you reduce and the cost savings, that's really challenging unless you're actually going to look at it in real time. That every single gram of waste that goes into that biodigester, we will be able to monitor and feedback so that you can then have an actionable insight. So if, for example, the grade A fertilizer is not grade A enough for our purposes, we can feed that back and say, well, your segregation at the front end isn't doing so well on March. But in April, it was wonderful because your waste champions could go out and say, look, let's start segregating a little better here. And for us, it's really important that if you're going to make an effort as a healthcare worker who's extremely busy, who's has a lot happening, and you're asking them to make changes in terms of how they segregate, and segregation, by the way, is the key to saving money and waste. If you're going to ask them to do it, it's really important that you help them and show them that it is creating something positive at the other end, and that they can walk down to the basement of the hospital and say, we have created a grade A fertilizer. We have created enough fuel to fuel 5 homes out of our hospital setting. And for us, like, that's really positive. And I suppose we've seen it happen with the prison services. They have a system of biodigestion in their facility, and works absolutely beautiful. They're so proud of what they produce, and for us, I think that's it's a really key thing to any of these initiatives, that you stay within the safety parameters of the standards. And when you were looking at standards and circularity, you have to be respectful of not just the class 1 medical device that you create, but also the standards in the other sectors, the standards of medical waste management, the standards of EPA soil guidelines, the standards of compostability. And I suppose that's the collaborative process that we've all been speaking about this morning. It's a journey. And I suppose that's maybe why I wanted to just talk a little bit through that. And I think maybe that's probably quite a quick tour of what we're doing. And it's been a great opportunity for us to see, can we make a change in something that is quite challenging? The last thing I'll say is we're not trying to take over all single-use things and make everything compostable. We think that the single-use PPE items, there's so many of them in the world. That's the throwaway ones now, not the ones you can recycle, reuse. We're real advocates that you have recycle, reuse in your system. But if you think about all your supply chain, all of the medical devices that you use in a healthcare setting, all of those have been made by people who have been wearing PPE. If you think of medtech, pharma, food processing, all those single throwaway items, the numbers and the volumes of waste and tonnage day after day that's created, it's extraordinary. And I suppose that's maybe on that note, I'll finish and pass you over to our next speaker, the lovely Emma Rogan, and Development Manager, and speaking about investing in children and their initiatives there. So thank you.
Thanks so much, Mary. Lovely to be here with you all today. Apologies for my slightly croaky voice, fighting off a bit of a cold. So I bet we're glad we're all online for those purposes. So yes, I'm Emma Rogan. I'm the Development Manager at Investing in Children, and I'm here to talk to you today about access to diabetes technology. So the other speakers we've heard from this morning have obviously spoken to you from a policy perspective, a practice perspective, a manufacturer perspective. And I'm here to talk to you sort of from a patient perspective, although I'm not claiming to be a young person with type 1 diabetes. I am going to tell you about some of the work that we've done. So just to give you an overview of what we do, so Investing in Children is a children's rights organisation. We're based in County Durham in the northeast of England, but we work regionally and beyond to promote the rights of children and young people. And we work across lots of different areas: health, care experience, heritage, arts, culture, and the thing that's at the heart of all of our work is creating spaces for children and young people to be involved in dialogue with adults that results in changes to their lives and the services that they use. So I'm going to talk to you today about our Type 1 Kids project. So Type 1 Kids is a regional project, so we work across the North East and North Cumbria ICB region with children and young people with type 1 diabetes and their families. And we do a range of activities bringing people together to kind of increase confidence around diabetes, that peer-to-peer support, but also our core purpose, coming back to that, facilitating that conversation, that dialogue that happens, that we kind of share with clinical staff and with the network. So as a result of our work through Type 1 Kids, we developed a project that we ran in a pilot last year around access to diabetes technology. So as some of you may know, diabetes technology is a rapidly developing area. So insulin pumps, continuous glucose monitors, which really allow for a high level of control, and people are very excited about access to this new technology. But what this technology requires often are high-spec mobile phones or laptops in order to use them efficiently and effectively. So the challenge that we were faced with, and what children, young people and their families were telling us about, was the financial burden about accessing the phones or the laptops that they needed to be able to then make the best use of the diabetes technology available. And in conversations about this, and we have criteria that our healthcare partners need to meet around increasing access to these pumps and monitors, particularly across the most deprived households in the northeast and North Cumbria, of which levels are quite high. So we were having conversations about this, and through those conversations, we simultaneously reflected that there was an opportunity here to help address some of the net zero targets and the kind of circular economy things that we've been talking about today, because hospital trusts need to consider the environmental impact of their unneeded IT equipment and disposal. So what this project did was bring those two seemingly unconnected challenges together and create a solution for them both by donating repurposed NHS equipment to families so that they could access diabetes technology and improve outcomes. So our partnership, we received funding from NHS England. My colleague Jenny Foster, who leads the North East and North Cumbria Children and Young People's Diabetes Network, headed up the work. She sort of connected to all of the clinics in the region and partners, and she held us all together. NHS, the Gateshead Foundation Trust, was our kind of key supplier of mobile phones and laptops that had previously been used by staff, had been rotated out of use by staff and were sitting in a room gathering dust. Ourselves at Investing in Children, we have that capacity to connect to families, have those conversations, and have remit beyond, the clinical staff are dealing with lots and lots of things in clinic. We have the space in our sessions and the relationships that we have to connect with families. And then we had another community partner, an organisation called Town and Community, who supported the refurbishment of devices. So we started the project with a donation of 400 phones and 25 laptops from Gateshead NHS Trust. Now, almost immediately, creative thinking was required because we thought this is such a fantastic opportunity. We're all really excited. The phones weren't being used within the NHS. We can get them out. We can get people using the technology that they need to be using. And we were told that the phones that we were getting were Motorola G8s, which were compatible with all the devices we needed them to be. On receipt of 400 phones at my quite small office, we discovered that they were actually Motorola G8 powers. And that little word power was really important because they were not compatible with the device, the sort of two monitoring devices, and they weren't compatible with one, and it tends to be the one that people want to be on and their preference for one. And it was a huge challenge for us right at the beginning. We now had over 300 phones that couldn't be matched up with the referrals that we were getting in from the clinical teams. Now, at that point, we could have said, well, we tried, and then we could have moved those 300 phones on and, whatever might have happened to them and hoped that they would have been recycled or repurposed or reused and not just disposed of. But actually, we made the decision that we were going to challenge the system. We wanted to create a sustainable system, and we were going to challenge that system. So what we did is we linked in with the industry partner, so Dexcom in this instance, and we were able to get them to test the Motorola G8 Power phones, and they've been added to the compatibility list. So actually with that kind of persistence, we were able to continue on the project as we had wanted to, and actually we increased the capacity for future sustainability, because that was a model of phone that we knew that if we were going to get more through Gateshead, they were likely to be that model. We wanted this to be a circular system that would work. So that required a little bit of creative thinking, and just a reminder that if you don't ask, you don't get, or as we say in the Northeast, shy bairns getting out. So it just gave us that additional motivation to ensure the success of the project. So we ran our pilot from in the last financial year, so 23 to 24, and over that period we gave out 298 devices to children and young people across the Northeast and North Cumbria. These were all devices that were recycled, repurposed from donations from within the NHS. So again, that kind of circular economy that we've been talking about this morning. Because we were able to prove it as a concept, we've been able to continue with the project as business as usual. So we've absorbed it within our Type 1 Kids business, that this is an added element of what we do. We have the connections with the partners that we now need to refurbish the phones, and we've streamlined the processes, and we are, Jenny, who I mentioned, who's the network manager, is in ongoing conversations to ensure that we've got that pipeline of devices coming through to continue to meet the needs of the families. So since April, we've been able to get another 70 devices out to children and young people. And it's really firmly been embedded within our system now in the Northeast. It's a project that's had a huge amount of interest, which is fantastic, because we want people to know about what we've done. We want people to think about how they can replicate it. We've been really lucky to be recognised with a couple of awards. So we won a Quality in Care Diabetes Award and an HSJ Digital Award to recognise the work that we've done. And what we want from that buzz and that kind of recognition is that people go, that's really interesting. I wonder how we could do something similar in our area. We've had interest in partners across the Northeast about how this could be replicated for other conditions, other medical conditions, where there is a need for using technology. And yeah, that kind of scalability of it. But what we're really pleased that we've achieved is an ongoing offer to children and young people around diabetes tech that is really kind of linked in with our NHS partners, and getting that getting those old phones out of that cupboard and that new lease of life. And I think the key thing about it, and it's sort of what Mary was talking about in her presentation as well, is about adhering to the functional needs of people managing their health. Above all else, so Mary was talking about the functional standards and what you need for PPE. What I would say from my perspective and the conversations that I've had with young people and families within this project, but as I said earlier on, we work across all different areas of discussion. I've been involved in other conversations around asthma, and with a particular kind of we were approached, could we facilitate some conversations about asthma, about dry inhalers, about meeting those net zero targets. And the feedback that we have consistently from families is it's got to help them achieve what they want to achieve in terms of their healthcare. And what we've managed to do is roll in those additional benefits with it. So it's looking for those creative opportunities to solve multiple problems at once, and involving patients in identifying problems and solutions, getting feedback from them, so that we're getting buy-in, so that it does become a sustainable project. This wouldn't have been a sustainable project if children and families didn't find it useful. They might have said, well, that if they said that wasn't something they wanted, we couldn't do it without them. So that's what I was asked to come and speak to you about. But and I think it sort of just ties up nicely that trajectory that we've seen over the course of this morning, looking at all different levels of healthcare, and where we can be having these really important conversations about where our practice can be more environmentally sound, where there are opportunities to think more creatively. try things out. I think there's been lots of talk of of piloting things and seeing what works and making those tweaks and making those adjustments. And that's a huge part of our work is that conversation with children, young people and their families about how they feel about it, and where it is that kind of patient facing end of things, about those conversations and getting their input in that evaluation to ensure that these processes work as well as they can to help meet all of the goals that we have around promoting good healthcare and within that sustainability model. So I'm going to leave it there while I still have a voice. And I think that's the end of our presentation. So we're going to move to the question and answer section of things now.
Excellent. Thank you to all of our speakers today. That was excellent. A really great way of looking at the different perspectives of sustainability and circular economy within healthcare. And I think it's good to bring it all full circle to see how everybody works together to achieve these outcomes, and how it's a team. It really is a collaborative effort to make progress. So we have had some questions come in. So I will start sharing those with you. I also have invited Nels Vac, my colleague from BSI here, as she is a standards manager, and some of our questions are related to standards as well. So feel free to continue to put your questions in the Q&A section, and yeah, we'll go from there. I will try to address the questions to specific panelists. However, if you feel like you want to contribute to a response, feel free. This is conversational, so very please feel free to jump in. I'm going to start with you, Lord James O'Shaughnessy. This is from one of our participants or one of our attendees. One of the challenges we are facing in moving to a circular economy model for single-use devices is that currently MHRA considers that Class 1 products should not be remanufactured, as there would be no external or independent assessment of CE mark compliance. And there are exceptions to this. Evidence from America and Australia show that safe and effective circular systems for Class 1 medical devices that have been in place for years. How can we lobby to change to this guidance?
A really, really good question, and just in the sort of constraints of time of the presentation, I probably didn't have a chance to go into it enough, but it really does seem to me to be the key to unlocking a lot of this, as well as, of course, recognizing the value of sustainability contributions through procurement processes and so on. I think it's true to say the MHRA has been a bit tardy so far in this regard. I don't think they would disagree. They've had a lot on their plate in the last 5 years, not least, obviously, Brexit, COVID, but re-establishing new regimes for medicines, medical devices, IVDs, clinical trials, and so on. So I'm not sort of excusing them, but I think there's the reason for that. What I would say is, from the Design for Life Advisory Group, first of all, this did come up as a major recommendation, that it was absolutely essential that the MHRA was prepared to re-examine its processes and be more proactive, perhaps is the right word, in looking at how to encourage manufacturers to go down these kind of routes and to learn from other regulators. And the good news is the MHRA was incredibly open to doing that, and indeed they are in the process of doing it. I don't have up-to-date information on exactly where they are in examining it, but it is part of the actions that the industry group recommended as part of Design for Life Advisory Group, and which the MHRA are taking on board. And as I mentioned, I've had an indication from the team looking after this at the Department of Health and Social Care that they have been greenlit to carry on with their work. So I would expect Exactly when I don't know, but I would expect in the next few months to see an indication of where that is in the pathway of policy change.
Excellent, thank you. And as being a member of the Design for Life, this is definitely an area of a lot of discussion. And I
Yeah.
think one of the challenges that we being an industry need to address is how about terminology, vocabulary. What do we mean by for example, reprocessed, remanufactured, so that we across all jurisdictions, across as we look at circular economy outside of the UK bubble, this is a global
Yeah.
a global practice that we all need that we need to work at globally. So we need to have some alignment on that from an international perspective. So I
Indeed,
think that's
indeed.
really
And
important.
one thing I would say, of course, there have been, think of, although it's in a way completely different, the contaminated blood scandal does raise heightened concern, I suppose, about the risk of contamination and patient safety.
Mm-hmm.
And so, if you're thinking about it from the MHRA point of view, the onus here, and this is why I think the research element is so important, is to be able to demonstrate that this can be done safely. So, not just to produce effective medical devices, say, or consumables or whatever it is, but that is done in a way that doesn't compromise patient safety, which requires an evidence base, which requires research. Who's going to fund that? So, I think the NIHR does have quite an important role as well in providing the evidence the MHRA can look at, and not just the NIHR, of course, all other research bodies from around the world, to gain confidence that this can be done in a way that is doesn't compromise patient safety.
Dr. Corsi, you want to add in?
Yes, I'd agree with you. I do wonder though where where the MHRA's links are to clinicians, because clinicians have the same desires and have a lot of expertise, hands-on expertise, and it may well help accelerate some of the progress because they do not want to see their patients come to harm in any way. So I think our aims are aligned. We are lucky within the CFSD that we have quite a big body of clinicians to tap into. And I think that has been one of the big accelerators of actions and adoption uh, kind of progress. So I would certainly very much recommend that.
Yeah, and sorry, just if I may, I mean, Philip makes a really important point here, as did Mary and Emma in their presentations. These are all examples of where the sustainability of medical devices is moving forward at pace in a way that demonstrably is not impacting patient safety in different settings. Making sure that the evidence is captured from that and then is used to create that growing pool of information that provides confidence is going to be important. And I suppose I wonder whose responsibility that is to both not just kind of feed that research, but then actually to collect, analyze it, and feed it in with, as Philip says, clinical support. It's not quite clear to me yet.
Kind of along the same topic of patient safety. So what, Dr. Corsa, how receptive are NHS infection prevention professionals? How receptive are they to making some of those theater changes that impact patient safety or could be seen as impacting patient safety, particularly such as the move from single-use to reusable compression garments, the change in single-use tourniquets, and so on.
So we engage very closely with them. Their anxieties are real. I don't think anyone should downplay them, and we wouldn't want to circumvent them. Never. It's about giving the evidence, giving the time to review and understand what it is that's going on, and that is where we've been working very hard with them. They want it. They want us to make change. They want us to be very environmentally friendly. They just want to make sure it's done right, and there's nothing wrong with that. So yeah, we've got them on side from the point of view of where we want to get to, and we're working with them on the evidence to make sure it suits everybody.
Excellent. And it's great to hear that the infection prevention professionals are still, yes, obviously very focused on patient safety, but understand the challenges that we need to face with sustainability. It's very similar to what medical device manufacturers, working with the MHRA and other regulators to see the same thing. So we all have unique challenges that we need to face, but working together, we can do that. Um, I guess from a Mary, this is for you, related to patient safety and products. But what testing, and what kind of testing, how rigorous has it been, for that's been done to ensure that the used PPE that you're providing, is rendered safe for the composting? What was that process like in getting that regulatory approval?
Yeah, so for us, it has taken a number of years to get to this point because, medical waste is, as I said, has an ick factor. And there's this idea that you're going to have composting bins on the wards with last night's salmon dinner and your medical waste rotting. So that's certainly something you got to get over. So it did take a bit of research. The first thing is that obviously there's certain guidelines that are already out there. That's the waste guidelines. And all we're asking people is to adhere to them as they're already written. We're not asking them for the segregation point to actually go outside of how they would put their waste. If you have a known infectious patient, that goes into your hazardous waste, of course. But if you have your non-visibly soiled stuff, it goes into the actual non-risk healthcare side. So we're asking them to just really adhere to that. But then on the other side, if you look at the risk of food waste, it's a droplet spread. You're eating it, it's close to the mouth, and nobody considers that a hazardous risk. It goes out as per usual to its if composting, if that's the facility. So if you look at risk just as we stand without any kind of change to practice, the levels of risk at different things are perceived in a different way. So we're saying, okay, how do we then de-risk belt and braces? So then we had to go through building our medicalized biodigester. And for that, you need things like having it at the correct thermal processing so that you get rid of the certain bacteria. You test all types of potential hospital pathogens like the escape pathogens, make sure that's all covered off. And then you add something like plasma, which actually then again creates a way of sterilizing your digestate for pathogens. So then you test that when it comes out the other side, and then you also test for plastics and other types of contamination. So that's the sort of microplastics end. And at that stage, you've got something that is, I'd say, better tested than if it went out to, well, obviously incineration. They're not going to test after that. But so I think it's all those pieces that you have to layer on, layer on layer on layer for safety. And yeah, so that's the process we've been doing. So I don't know if that answers, if there's.
It kind of seems like we need to change our perception of ick. Of
Oh
what is
yeah,
that?
oh for sure.
Now that you talk about the food, I'm like, oh, well, all right then.
I
I
know,
hadn't
you
thought
see,
about
that's an unseen standard that everyone sort of puts in their mind. Oh
that.
God, and that's the hardest
Yeah,
one to get
you're
over.
right. Yeah, I'll be careful about what I eat now. um, this I'm going to go back to you, Phil, because this is a similar concept with the concept of the reusable sharps bins. Um, this is from one of the attendees. How is the waste inside those reusable sharp bins? How are they? How is that dealt with? And are the bins are the full bins sent off to a waste processor who then cleans them and sends them back empty? Do you have any insight onto that process? Which is interesting because I was at a conference last week and this was very much the focus of that discussion.
Yes, I mean, there is a very clear process that you work with the supplier. So you have a supplier who brings the right piece of kit. You need to make sure you put the right sharps in there. I mean, if you were to open a sharps bin today in my establishment, you'll see a lot of plastics, you'll see a lot of material, you see a lot of all kinds of stuff. So it's actually about the good application of the rules, as it were. But no, this is not done in-house. This is very much a separate process, which is very well regulated and tested. I think what Mary's just talking about there is important. You can't just do something because it sounds right. You need to have the evidence that it's safe, that it's effective, and it's not going to cost you more or actually cost you more energy to do it. And once you've done all of that, you then say, okay, well, I have a process here which works and works well. I'm not going to go into any detail here, but if you contact us, I'm sure we could give you some information on what we've looked at. We don't have it yet in Scotland. We're still working on making sure that we tick all the boxes that allows us to do it well. We know it can be done well. It's not yet systemic. That's the difference.
Excellent. It's really a profile raiser for our waste management experts within NHS. All of a sudden, they're rising into the spotlight with all these waste initiatives. Emma, not to leave you out of the conversation here. What have you the program that you're doing is really, really interesting, and you mentioned how you've been contacted to kind of by other areas to expand or to get information on. Have you done any, or has there been any reporting done on the impact of the Type 1 Kids program, the impact that the program has had on both children's health and their confidence in managing their health, as well as the sustainable impact? How much waste have you taken out, and so on? Has there been any of that reporting?
Yeah, so we definitely have reporting on the impact that it's had on kind of healthcare. So from families' perspectives, we had one really good instance where actually, there was a mother who was parent to 2 children with type 1, and she had to choose which one she followed. You couldn't follow 2 different children on your one phone, so an additional phone meant that she was able to follow both her children and didn't have to choose on a day-to-day basis which one she was tracking the levels on. So that's made a huge difference to her life. We've had feedback from a number of young people with autism, which has meant that having the phone has allowed them to use the device, which has reduced the need for injections and needles, which there was phobia around. So it's allowing them to manage their diabetes with much less distress. So yeah, we've had lots and lots of feedback about the impact from a healthcare perspective. We've got really good data about the impact from a deprivation perspective, and the model that we took was that it was there was no criteria for access. It was open to anybody, because we've done work around poverty proofing and justice principles. And actually taking that approach, we still, the households that we got the devices out to were still in those most deprived ones overall. What we have less data on is that data, and I've made a note about that data around the environmental impact. So we know the number of phones that have been reused, but actually in terms of, but like getting into the detail about what that impact is and what's been what's been saved, we don't have that, and it'd be maybe a conversation to extend about how we capture some of that information going forward. But because we had sort of a spread of priorities going into the project,
Mm-hmm.
and there was the sort of opportunity to have this sustainable angle as well. It was sort of it wasn't a bonus because it was something that was really important to us, but the level of data that we have around collecting that is just the number of phones that have been taken and reused.
I think this is an excellent initiative, and I would like to see, I think that there's probably opportunities to hear about lessons learned and the challenges that you went through, so that they can be applied to other initiatives within or in collaboration with the NHS. For example, the walking sticks, the walking aids, crutches. How do we recycle, reuse those, get them back into environment rather than just throwing them away and seeing all the waste? Because I know I've got some wonderful walking aids and crutches that I would love to get out of my airing cabinet, because they're just taking up room right now. So yeah, thank you for that, and hopefully we can follow up and get some more information. James, what does you were talking about whose responsibility is it for some of these sustainability initiatives and stuff, but when we're talking about moving to a circular economy and doing these things, there's inevitably a cost associated with that. changing a device to make it more circular is going to impact the overall cost of that. But where is this funding going to come from if we can't get devices into the NHS because of cost points, for example? How is that going to work? And are there any incentives being considered to help manufacturers move along those transitions to circular economy?
Yeah, I think it's a great question indeed. It was the sort of question I was going to ask my fellow panelists with all their initiatives about whether they are seeing increased costs, which of course one can potentially justify through value generation. However, however you want to count that, but nevertheless does increase costs. I think we have to be, in the UK at least, we have to be realistic, and I don't really think it's different in any other country. Costs of care are rising, aging populations, increasing morbidity, falling healthy longevity. All of these kind of things mean that the costs and pressures on all healthcare systems are growing, and the NHS is no different. In fact, it's probably more acute than most places. So I think the first thing we have to admit is that there's not going to suddenly be a whole load of money coming out to pay higher prices for things. So that creates pressure, I think, on two sides. One is industry obviously needs to keep innovating. It needs R&D support, which of course the governments do provide, in order to innovate in a way that we've heard from colleagues this morning. But the onus is on industry to try and be as cost competitive as possible, so that when you're going through the boring procurement and other processes, these products look competitive. The other is it might be possible to create some headroom within existing budgets. And we've already had David Lawson, who runs the Directorate in the Department of Health and Social Care, talk about the opportunities for consolidation within the £10 billion a year the NHS spends in England. So you can obviously multiply that for the UK on medical devices and other technologies. There is huge variety in procurement processes, in pricing, in other things, which create opportunities for value generation, frankly, reducing costs, or alternatively using that money in order to generate further value. And I think that is, in a way, probably the policy argument that needs to be won. If there are ways of creating more streamlined approaches where purchasing is done on scale, working with the clinical community to ensure that adoption happens, so we get high uptake of these kind of new sustainable products, it may be possible to create space in existing budgets to pay whatever premium is required to help fuel this transition. But I do think we need to be realistic. There isn't suddenly going to be a pot of money to start paying more for things, because inevitably, if there is money, people want it to go on doctors' pay, nurses, new drugs, the kind of innovative treatments that the NICE isn't signing off. So, yeah, I hope that gives you an answer. Maybe not the most optimistic one, but a realistic and I think achievable one.
Yeah, regarding incentivization, that was and continues to be a big discussion in the Design for Life work.
Yeah.
So how do we, to help motivate and encourage in the lack of current regulation specific to sustainability and circular economy within medical devices, how do we get manufacturers to do what is right? What's the right thing to do when there's a cost associated with it?
Yeah, and look, there's other issues, right? I mean, obviously, most medical devices don't go through NICE, so it's probably got to feature more in the MHRA regime. That's got to, as we've discussed already, it's got to make it easier. Things like energy costs, those have tripled industrial energy costs in the UK. That does make the kind of onshoring that Mary was describing harder. If you're looking at these kind of devices, so we've got to find a path to cheaper, sustainable energy quickly. In order to help industry to achieve what we want to do.
Excellent. Phil?
Thanks. Yeah, so cost is an issue. Finance is not really plentiful. We know that. Most of the projects that we've come up with are cost saving. And we initially weren't reporting that, but we've started doing that. So you get the cost saving and the CO2 tonnage saving side by side, which gives you an indication of what benefits you're going to get from what you do. There are some clearly that have a cost to them. And it's just like writing a business case, because if there is some efficiencies to be made, and most of the things that we're looking at how can this be more efficient, i.e., you know, it's not just a swap one for the other, but as part of that swap, there are some efficiencies to be made. And that's where, again, the clinicians in the room makes that difference. We talk about lean trays, for example. The most simple one that we've come up with is changing from intravenous paracetamol to oral, literally. Oral paracetamol that you can buy over the counter for very cheap versus all the plastics and bottles and infusions and everything else that goes with giving an intravenous infusion to someone who's just walked in off the street for an operation. And this is before the operation, or during the operation. You give them paracetamol before they go in, they'll take it and they'll be very comfortable. And that on its own has a cost saving. So we're adding all that up. We're calling it a green dividend, whatever that means. Um, but we're trying to make sure that that is seen. So when we do come back and say, well, this will save you money over 3, 4, 5 years, that can be put up against the saving that you've already made. The downside is it's not hard cash, because if you make savings, that's already gone on someone else's salary or it's gone somewhere else. So there's also being mindful that there's not you're not handing over cash, you're just making savings. But it's a conversation.
Yeah, that's really interesting because it's almost like we're stepping back and simplifying some of our processes. I mean, to me, it seems like using an intravenous for delivery of paracetamol is very more complicated than just giving an oral tablet. So maybe we can learn something from simplifying our lives. Kind of along the discussion of costs, Mary. This is one from another one of our webinar attendees. Comment that your biodigestion process looks great and can really save money in the long run. However, a barrier to implementation would be the initial cost to a hospital to set that up. Is there just a one-off payment to do this, or is it an ongoing cost that must be faced by the NHS? Wondering how hospitals will finance that with the current financial constraints that they face.
Yeah, so that's a really big issue, obviously, as we were just spoken about here. So we looked at our business model as well, and that's why we wanted to provide a services-based business model, so that it's actually you provide the whole end-to-end service of the product and also the biodigester. And in Ireland anyway, it seemed to be a little easier for a sort of a leasing model to be sort of in place rather than per se a large capital outlay from a hospital. So we're very open to working on whatever business model, whatever way of doing it, step by step. You know, if whatever kind of budget it can come out of, and that makes us quite amenable to going into different institutions because they might have different setups. So we're agnostic to how we do it because we understand the cost implications for acute hospitals. We also said because of our products, when we develop other pieces in our range, could be used in other industries that supply healthcare, that also helps to manage upstream scope threes. You know, that we'll say your medtech industry might have a bigger budget to spend on sustainability because of their need to have mandatory reporting. So if they're changing how they're using their PPE kit, reducing the amount of plastics in the world, they're supplying then into an acute health service. So it all still assists. It just might not be, you know, and it might not just be seen at the healthcare service front out we'll say you might not get it in very fast in the health service, but you could look at other industries where it could go into that would assist, you see. So I think we're thinking outside healthcare also for impact on health, you know. So
excellent. Emma, you working with the healthcare facilities to get the mobile phones, the mobile devices. Did you have to, I mean, it seems like, it would be a program that they'd be happy to contribute to, but was there any, talking to them like, this is how this is going to benefit you? Was there any kind of a that talk about incentivizing to help get the hospital to contribute, or how did that go when pitching the idea to the hospitals?
That's been a really interesting discussion. So Gateshead Foundation Trust, which is one of the foundation trusts within the North East, have been on board right from the beginning. They've been really, really supportive. Finding other sustainable streams of donations has been a challenge. And we've had individual people who said, oh, you know, because there's different processes in different hospitals about how often technology for staff gets replaced. We've had some people who've been really interested in the program, but what they're offering is, oh, we've got 10 phones, and we need it to be on a larger scale than that for it to be, you know, as sustainable as we need it to be. So that's been part of Jenny's role as the network lead, trying to find different streams, and that has been a challenge. There have been times where we have linked in with other tech refurbishment companies. So there's an organisation in the Northeast called Furbed IT, and they refurb devices, and we've linked in with them, and they've been able to provide us with really specific devices when we've needed them, because in terms of that compatibility, we've needed some very specific things at times. But yeah, that's an ongoing challenge, Lena, around finding a source other than Gateshead, because they're not going to replace their phones, you know, just to suit our needs. So finding other devices, and that's also when it comes to the scalability of it, there is that interest from other parts of the system, but you need that supply coming through. And it's linking up with the right person in the hospital. So we'll get clinical staff saying, this is a great idea. We've just all been given new iPhones, so there should be some 2-year-old iPhones kicking around somewhere, but finding the right person who has the authority, you know, who knows where they are, who has the authority to say, yes, we can release them, or, you know, or donate them, and has been more challenging.
Well, hopefully, fingers crossed, with the release of the new iPhone 16, you'll get a big surge of new of not so old iPhones coming your way as the new ones are rolled out. Mary, I'm going to come back to you. There was a question that came in following the last question regarding the overall cost of financing this type of a system. Would the cost of the PPE be the same percentage for acute use versus mental health use and so on, based on the various departments and what would need to be done to the PPE for the compostability?
We actually made it to the class 1 standard for across the board, and that's also for clean rooms, no matter where they would use this particular item. We said, let's bring it to the standard so everybody then has a comfort that it's reaching the regular low density polyethylene one. So they're always going to be compostable no matter where they go, because it's soil safe. Technically, if it ended up in a general waste and was incinerated, it's like burning vegetables. You've less sort of dioxins in the atmosphere, etc. It's still going to be, if it goes that direction, it's still not great. But if it ended up, we'll say, on the land somewhere, it's still a soil safe start. So we're happier with that, but it's still not optimal because you want it to be an industrial composting process that you control, and therefore you can get the value out of it. So it really depends on the size of the unit. It depends on what the amount of food waste, for example, they have too, because you have to monitor the wet and the dry waste inside in the biodigester and all of that side of things. We're trying to develop a thing called a resin recapture system for the other industries that don't use food. So it means that you get a beautifully circular model of your PPE. So you basically have your resin your PPE wearing, and because it's not in any way contaminated by anything, it can then go through a resin recapture, and you actually then get to that. But that's a little further down, and we're using and leveraging funds outside of healthcare in order to bridge this gap, because we totally get it. I've been in health so long that I know the drawbacks, and I know a lot of procurement officers, and so I do understand that. That's why we're using that kind of research end to push some of this forward, and I'm not sure if that can answer the question in particular, because it sounds a little bit like different units may have different usage of PPE and different kind of food element to the health side, if the mental health or that was the question, as in, does it differ according to the sector? But
really interesting, and I have to say I'm very pleased that that a number of questions that you've answered, you have mentioned standards. I would be remiss.
Oh yeah, okay.
I would be remiss being a working for BSI if I don't throw in a question or two regarding the standards and the impact that it has. So I'm going to ask this one to Nell. We got this from an attendee as well. Where and how do you identify standards to assist UK manufacturers with developing sustainability strategies and solutions. Where are these? And I'm going to talk a little bit about some of those standards later on, but where would somebody access these?
Yeah, it's a good question because there are a lot of standards in existence. We have energy management, waste management, greenhouse gas management. So the overarching horizontal standards, we have a lot of them. So I'll put in the chat in a moment the page where we have links to those specific ones. But I just wanted to also point out with what Mary was saying, there might be some industry standards that are not medical device specific, but other industries where we can also learn from. So I would recommend doing some searches on our general knowledge page as well for specific topic areas. And then you can build out a good catalog of things that you can have a look at that can really underpin where you can start from, because that's often the problem. Where do you begin? So we are looking into a little guide that can show you where to start and what kind of standards already exist to help you. And we also have a report I will mention a bit later on, but I'll put in the chat some of the pages you can go to, as well as our standards development page where you can see what's in development, so you know what's coming, and you can even comment on those. So yeah, leave it there for
Great,
now.
thank you. So we have about just under 20 minutes left, and there's a couple more slides that I want to talk about kind of what BSI is doing. But for our panelists, give you a minute or two just to kind of address some final words, thoughts, what you think are your biggest challenges from your perspective that need to be faced, and how can we as an industry help minimize those challenges? How do we work together to help you with what you're facing? James, can we start with you?
Sure. It's been a really interesting discussion, and I think I sort of go away encouraged by the willingness and actually some of the actions that are already happening at ground level. Clearly, it needs, though, a national and cross-national effort, and I wouldn't underestimate how difficult this will be to achieve from a policy-making perspective. Because everyone people almost have a feeling that somehow policymakers have some kind of inviolable wisdom more than anyone else. The truth is, if you're sitting in government, you're trying to juggle 101 things with generally really poor information, and it's hard, right? And this is a really hard macro challenge. So what that means is that it cannot happen without the ideas and prompting and lobbying and all the other things that have been talked about, innovations that have come from the grassroots level, whether that's in hospitals, whether it's in community care, whether it's in devices, consumables, supply chain, whatever. This will only be solved collaboratively. And it's really imperative on industry, not just to show a lead. Of course, you've also got to run businesses and be profitable and keep your staff in their jobs, but to actually provide solutions to the problems that governments are trying to wrestle with, because they are not going to invent them all themselves. And if they do that in a bubble, then it won't be the right solutions, because they won't work for the people who, as we saw from that chart, are actually responsible for reducing emissions and increasing circularity and so on. So I guess it's a plea to everyone on this call, and indeed more broadly, to continue engaging with government as much as you possibly can to help solve these problems.
Excellent. Thank you very much for that. Phil, how about you?
Yeah, so I would agree with everything that Lord O'Shaughnessy just said. From our point of view, this National Green Theatres programme was set up by the Scottish, with funding from the Scottish Government, and despite the constraints, they've continued to support us, which is good. So we do report back up through the processes and not to the Value and Sustainability Board. I think it's important that we also remember that this was created by the grassroots, and we keep the grassroots clinicians involved. Not just clinicians, we're talking about procurement, we're talking about estates, talking about the engineering community, and we need manufacturers to get in that space. I think that's where it gets difficult because the procurement rules don't necessarily allow you to do that quite as easily. And we need to find a way of doing that without the barriers that are there. And for manufacturers to understand that we will, going forward, be asking about the environmental sustainability benefits, credentials of the things that we're going to be buying. And, please bring that forward as one of the benefits or the USPs of your product, because that's what's going to be coming up.
Excellent. Thank you. Mary.
From our perspective, I think one of the greatest barriers, well, there was two actually, and that was our business model doesn't align with current procurement practices in terms of PPE being divorced from waste. So that's a challenge. If you're going in with a services-based model, where do you actually apply for that? There isn't an area. So we're hoping that there'll be a smoother path to innovation procurement arm. So for example, in Ireland and Europe, there is innovation procurement mechanism, but we've never drawn it down in healthcare. Probably because it's difficult to prove that you're an innovation to the degree that is required for the EU rules, but then also the willingness and appetite to go in with a group for innovation procurement, because it does take a bit more effort than just putting a tender out. And that's, by the way, putting a tender out is an effort in itself, but then going above that to actually stand behind to see, can we bring a smaller group in and deal with a specific problem in an innovation procurement way? So if we could smooth that out, I'd be absolutely delighted,
Excellent. We've got some challenges ahead. Maybe we can help you. Excellent. And Emma, how can we get more phones for you?
Well, I was going to say, if anybody's well connected, my email address was on the slide, so do get in touch. I think we've got that. That's a kind of an ongoing challenge about the sustainability, bringing things through. I think it's highlighted for us that need around how we capture some of that environmental impact in a more detailed basis to make those arguments going forward. I think linking to what other people have said about keeping that connection to the grassroots, that's a constant challenge with my job about when policy is put into reality, that those conversations are happening with those end service users and that they're part of the discussion and any tweaking that needs to happen. So it would just be an encouragement that where people are involved at that end of things, that, the patient voices are not just gathered, because that always makes me think that they're then arranged nicely in a vase, but actually are really meaningfully part of the conversation and linked into how changes are made. And I think one of the challenges that I mentioned that we overcame, one of them in our project, but really highlights the need for creative thinking. So when we had that challenge about the lack of compatibility, is encouraging people to be creative. And it's not, where everybody's working in very stretched systems and creativity requires time and resilience and resource, but that there are the creative solution is not always a complicated solution. It requires you to think outside of the box sometimes, which is a difficult thing to do.
I think that was also something that Phil brought up with the intravenous versus just oral. Sometimes it's just go simple. It doesn't. Creativity does not mean complicated. Well, I want to thank all of you, James, Phil, Mary, and Emma, for contributing to this discussion. I thought it was very insightful, a lot of good information, seeing all the 4 different perspectives and how we're all working in this together. And I hope that everybody else found it just as compelling and interesting as well. I do have just a couple more slides just to close out the session. And then we do have some call to actions for everybody related to this, because we are all kind of in this together, and we need to figure out a way to continue to manage this process. Let's see, next slide then. Lou, I think you've got, there we go. All right, so I just want to point out some of the standards work that we are doing within BSI. We held a workshop in June and brought manufacturers together to talk about some standards, and this is a horrible slide to read online, but it will be available in the information that you receive along with the recording. But it talks about some of the standards that can be used to enable circularity in healthcare, really identifying different areas, ranging from materials to the devices itself to more looking at processes and that the calculations, the measurements that are needed. So take a look at this and some of the suggested changes that that BSI are exploring in order to help manufacturers and potentially NHS as well as they look at using some of our standards as well to become circular. I like to say a circular ecosystem rather than a circular economy, because the ecosystem really brings in all the different aspects that we require, the 4 different perspectives that we have here, because we are all working in this together. We're not in silos for that. So with that, there's one more slide, and with our call to action, and I'm going to ask my colleague Nell to talk to these before we finally close out.
Yeah, so first of all, I want to say thank you to everyone for listening to the conversation today. And my call to action to you really is to continue this conversation. So speak to your wider network. I know in the past we might have been working a lot more siloed, but in order for actually to achieve the results, I think we do need to work together more. And this could be the first step to do that. Start talking to your network and see what has been working well for them, what has been working well for you, and share that so we can actually start developing some solutions that will work across the board and can also influence standards that then again can influence even more companies worldwide. So that's our aim at BSI, to make that change globally. And I also want to ask that everybody really thinks challenging themselves. So I've heard it twice today to say, are we really challenging ourselves enough? How many considerations do you have about sustainability already? And are you already doing things like life cycle assessments for your product lines and setting targets for that? So really thinking about, okay, how can we take the next step to push ourselves towards it? And then hopefully, if that's been successful, sharing that success with us. And then I also wanted to say that being part of standards is something that's very common. I know that maybe you're not aware of it yet, but standards development is created through partnerships with all sorts of organizations, end users, research organizations, government. So we all want to bring everyone together to make the changes that are needed and are practical on a day-to-day basis for organizations. So please have a think about some subject areas that you're interested in and think if you could maybe contribute to those committees. We're very much in favor of, at the moment, hearing about, okay, you have started implementing some changes. Can we bring that into the standards world? So let us learn from your experiences, bring that into the standards world to make the changes for each individual subject area. If that's not something that you can commit to, there are other things that you can do to influence standards for the greater good, such as commenting on public commenting phases of the development of each standard. You can submit ideas for new standards to be developed. So if you notice a gap in the standards that you needed that we don't have at the minute, then please reach out to us. We're very receptive to discuss any potential ideas. So do come forward to me or Lena. I'm happily to put my email address in the chat so you can speak directly to me if you would like. And as already alluded to earlier, we have a whole range of horizontal standards that you can start to use to implement some changes. For example, if you've not done life cycle assessment in the past, we have 14,044 or 14,040 that can give you some principles, guidance to actually start doing that. So please have a look at those standards. And very importantly, if you have used them and you've seen what might be missing, elements missing specific for the healthcare industry, we'd love to hear from you and maybe even do a case study with you that we can allow other people to learn from your journey. That'd be fantastic. And then finally, just the final call to action is to download that report that Lena was talking about, read about the challenges people have shared with us, similar to what we've heard today, but in a bit more detail, and what our kind of next steps are for those projects that Lena has pointed out. And if you want to be involved, either in a workshop, by commenting or joining a committee, then please reach out. I'll put my email address down. Thank you. Over to you, Lena, for close. Not sure she's coming back. Maybe I'll mention the last parts. So thank you very much, everyone, for coming today. Really appreciate it. There are some upcoming webinars that you might be interested in there on the screen now, and you will get the slides sent to you. So please have a look at those slides and take the actions that you would like to take from today. So thank you so much for attending.